So good evening all. Hope I'm audible. So today we are going to have so I think we'll start the class. Hello, checking. Checking. Hello. Yes, we are live. So I think we'll start the class. Hello, checking. Okay, fine. So today we're going to see the interesting topics like oral cavity cancers, neck swellings, salivary gland swellings, thyroid swelling, breast hernia. All these chapters we are going to see today. All these are clinical topics. So I think you will be having more number of questions from this chapter. So please have an idea. So all the QRP sessions are available in Dr. Tutorials app. If you're unable to attend, you can always visit the app and you can see the videos there. So there are multiple power plant packs available there. We have the most economical plans for all the students. So log in into Dr. Tutorials app for your success. And we are going to start today from oral cavity. Can you tell me what is the surgery here? So please post all your doubts when we are discussing. So we'll be discussing all of these things. So what is the surgery done here? Can you tell me what is the surgery done here? This is a classical surgery done for oral cancer with the neck nodes. Oral cavity cancer. With the neck nodes, we have done a surgery here. What is the name of this surgery shown here? That's a question. So this is a surgery showing you a radical neck node dissection. So please don't forget it is a radical neck node dissection surgery shown here. So in a radical neck node dissection, what are the things we are doing here? In a radical neck node dissection, it's a highly expected MCQ from oral cavity topic. So in a radical neck dissection, what are the levels of neck nodes removed? Should not forget the levels of neck nodes. I'm going to show you the nodes. Level 1 is submental submandibular nodes. Level 1 is submental and submandibular nodes are level 1. Level 2 is upper jugular nodes. Level 3 is middle jugular nodes. Level 4 is lower jugular nodes. Level 5 is posterior group of nodes behind the sternocleidomastoid. That is level 5 is posterior group of nodes. Level 6 is pretracheal and prelaryngeal nodes. So I hope you know delphic nodes are prelaryngeal nodes. So prelaryngeal nodes are delphic nodes and level 7 is upper mediastinal nodes. So these are the neck nodes. You should have an idea before going to the discussion of radical neck node dissection. In a oral cavity cancer, there will be a systematic spread of cancer from oral cavity to level 1, level 2, level 3 like that. There will be a systematic spread of cancer. Except tongue cancer can have skip metastasis. All other cancers go in a systematic way from, for example, from the cheek to level 1 to level 2, level 3 like that. So it goes on like that. So what we do in a radical neck node dissection, R&D, it is also known as Kreil's operation. It is also known as Kreil's operation of radical neck node dissection. We remove 1, 2, 3, 4, 5. We remove the nodes in this group. Level 1, level 2, level 3, level 4, level 5 group of nodes are removed in radical neck node dissection. And while I am removing these nodes, what I will do is, along with the removal of nodes, I will also remove 3 important structures. What are they? They are known as SIS. You remember them with the mnemonic as SIS, spinal accessory nerve, internal jugular vein, sternocleidomastoid muscle. So these are the 3 structures removed along with that. Spinal accessory nerve, internal jugular vein and sternocleidomastoid muscle are the 3 structures which are removed while doing this operation. All these 3 structures are removed while doing this operation. And along with that, we also remove the submandibular gland. Also, we remove the submandibular gland. We also remove part of parotid gland, not the full gland, but part of parotid gland is also removed. So last year there is a question in radical neck node dissection. What are the structures you preserve? Don't forget what are the structures you preserve in a radical neck node dissection. Many students get confused between MRND preserved and radical neck node preserved. So in radical neck node dissection, the structures preserved are common carotid artery, vagus nerve, lingual nerve, hypoglossal nerve are the structures preserved in a radical neck node dissection. So please don't forget, structures preserved are common carotid artery, vagus nerve, lingual nerve, hypoglossal nerve. So in this picture you can see those structures being preserved. You can see in this picture those structures being preserved. This is common carotid artery, this is vagus nerve, this is hypoglossal nerve, this is a lingual nerve. All these structures are preserved. But we have removed, you can see the submandibular gland removed, some part of parotid gland is also removed. We have removed the sternocleidomastoid, internal jugular vein, spinal accessory nerve. So this is a classical image of radical neck node dissection. So don't get confused between the image of radical neck node and modified radical neck node. So radical neck node is what commonly done by many surgeons. Oncosurgeons, they usually do this. They remove all the nodes. They remove sternocleidomastoid, internal jugular vein, spinal accessory nerve, everything they remove. They leave only carotid artery, vagus nerve, lingual nerve, hypoglossal nerve. So you can see radical neck node dissection results in loss of so much of function. So to preserve the function, we have some modification that is known as MRND. Modified radical neck node dissection is also known as Bocca's operation. Everything is same except in this modified radical neck node dissection we preserve SIS. We preserve these three structures. This is 100 times asked MCQ. What are the structures preserved in MRND? Sternocleidomastoid muscle, internal jugular vein, spinal accessory nerve are the three structures preserved in modified radical neck node dissection. So please don't forget what are the structures preserved in MRND. Sternocleidomastoid muscle, internal jugular vein, spinal accessory nerve are the three structures preserved in MRND. So please don't forget these three structures. These points you should never forget. Everything else is same. There is a question in INA common entrance test. So not old AIIMS pattern. This type of MRND is known as type 3 MRND. Type 3 MRND, all three are preserved. SIS is preserved. So preserve type 3 is, I don't know. Okay, sorry. So I will write it on the right side. So this is a type MRND, modified radical neck node dissection. Sternocleidomastoid muscle, internal jugular vein, spinal accessory nerve are the three structures we preserve in MRND. There are three types of MRND. So as Azhar is asking, we are going to preserve three structures, and there is a classification of that. In type 1 MRND what we do, type 2 MRND what we do, type 3 MRND. Type 3 MRND, all three are preserved. When type 1, we preserve accessory nerve, spinal accessory nerve is preserved. In type 2, two structures are preserved. Spinal accessory nerve and sternocleidomastoid muscle are preserved. Only internal jugular vein is removed. So this question can come for your exam. I am not sure it may come, but it can come for your exam. So please remember, type 3, all three are preserved. MRND, what I am discussing to you and what is asked in the exam is, in MRND, what are the three structures preserved? The three structures preserved are SIS. Spinal accessory nerve, internal jugular vein, sternocleidomastoid. In type 1, only spinal accessory nerve is preserved. Okay, only one structure is preserved in 1. In 2, two structures are preserved. 2S is preserved. In 3, all three are preserved. This can come for exam. Okay. This you should not forget about. Modified radical neck node dissection. So what is this operation you are seeing in the image now? Here we can see radical neck node dissection is done. Along with that you can see some amount of mandible is missing. This is known as commando operation. Commando operation. What is commando? Combined. So please remember, commando operation is combined mandible neck node dissection. So this is done for cancers. Commando operation is done for cancers in which there is the cancer infiltrating into the mandible. The cancer is infiltrating into the mandible. Very good, Sivagita, that's correct. So commando operation, the cancer is infiltrating into the mandible. We have to remove the mandible along with all the level 5 nodes. That is known as commando. So combined mandible neck dissection operation is done for oral cancers infiltrating mandible. infiltrating mandible, this is done. So please don't forget this point. It's an essential point for your exam. I need you to remember this combined mandible neck dissection operation. So, and I always get a question from the from various groups about the students asking, sir, which are the staging we should remember for exam. So I'll tell you there are two stagings you must remember for your exams. One is breast cancer and another is oral cancer staging. So please don't forget, oral cancer staging can come for your exams because these are the common cancers in India. So therefore AJCC 8th edition oral cancer I am going to tell you now. I am going to tell you oral cancer staging for exam. So oral cancer staging T1, T2, T3, T4. Less than 2 centimeter it is T1, 2 to 4 centimeter is T2, more than 4 centimeter is T3, T4A, T4B. Removable structures will come under T4A, like skin, the cancer involving the skin, involving the lips, like some facial skin which are all removable. So non-removable structures like carotid sheath, pterygoid plates, all those come under T4B. So this is a very simple staging as per 7th edition, but 8th edition they added one new point. Can you tell me what is added in the 8th edition in T staging? Anybody? What is added in the 8th edition? New point which is added. They included depth of invasion also. They added a new term known as depth of invasion in AJCC 8th edition. In previous edition it was not there. Depth of invasion was not there. Now they added depth of invasion also. So depth of invasion of the tumor less than 5 millimeters, 5 to 10 millimeters, more than 10 millimeters. It is known as T1, T2, T3. So whichever is present you have to, for example, a patient having a 2 centimeter size tumor with a depth of invasion more than 10 centimeter means we should put T3. The biggest one should be taken. So depth of invasion more than 10 millimeter but small size 1 centimeter also we should go for T3. So this is a simple T staging. So please don't forget, it is a simple T staging, you should not forget. Are you clear? T staging. Similarly, N staging, N1, N2A, N2B, N2C, then N3. So very simple staging, but definitely you will get exam question from this because this has been asked 2 to 3 times in the exam. So N1 is less than 3 centimeter single node. So single node less than 3 centimeter comes under N1. N1 less than 3 centimeter size nodes. N2 is for 3 to 6 centimeter size nodes. N2 is for 3 to 6 centimeter size nodes. If it is single, it is N2A. Ipsilateral on one side, multiple, it is N2B. Bilaterally present, multiple nodes are seen, which is 3 to 6 centimeter, it is N2C. N3 is more than 6 centimeter node. So simple again. So N1 less than 3 centimeter, there is a node less than 3 centimeter is N1. 3 to 6 centimeter single node is N2A. 3 to 6 centimeter multiple nodes on one side is N3B. On both sides is N3C, N2C. N3 is more than 6 centimeter. So what is newly added in AJCC is they added N3B. What is it? N3B. So whatever is newly added, I am telling you because they may ask you a question. What is the newly added concept? What is the newly added concept? Can be asked in your exams. N3B. What is N3B added? They included extra capsular extension. Please remember, they included extra capsular spread. They included extra capsular spread also. This is the staging. Please remember, N1 single node less than 3 centimeter. N2A single node greater than 3 but less than 6. N2B ipsilateral. N2C bilateral or contralateral. N3A is more than 6 centimeter. So definitely you are going to get a question from TNM staging of oral cancer. Please remember TNM staging of oral cancer because I hope you all will be remembering CA breast because it's being repeatedly asked. You will be thorough with the CA breast. But most of us go without proper knowledge of this oral cancer. There is a latest staging, AJCC staging for oral cancer. Please don't forget this staging. So T4A is invasion into adjacent structure which are removable like bone, floor of mouth, skin of nose, chin, skin of face. So these are all removable. Non-removable structures like pterygoid plate, carotid sheath, masticator space all come under T4B. So it comes under T4B, that is TNM staging. Please don't forget TNM staging of oral cancer. I have to stage them now. Staging 1 is T1N0M0, stage 2 is T2N0M0, stage 3 is T3N0M0. Very simple. So we have to categorize them under AGC staging. 1 is T1, 2 is T2, T3 is stage 3 is T3. So N1 comes under stage 3. Please remember N1 comes under stage 3. There are 4A which is T4A, 4B T4B, 4C is metastasis. So 4B and stage 4C are inoperable cancers. So you can see stage 4B and 4C are inoperable cancers. Even you may not remember this, but staging you should remember. Even you don't remember the grouping, it's not a matter, because they may not ask you the grouping, but they will definitely ask you the TNM staging by giving a lesion. Okay, they will be asking you a TNM staging by giving a lesion. So just remember them clearly. So if you have any doubt in oral cancer, please tell me. Any doubt in oral cancers? Oral cancer is a high yield topic. Any doubts if you have, please tell me. Okay. So now coming to the parotid gland tumor related topics. So there are high yield MCQs from parotid gland tumors. So now the question from parotid gland surgery, parotidectomy surgery. So in the parotidectomy surgery, the first step while I am doing operation will be to identify the trunk of facial nerve. So my first aim is to identify the trunk of facial nerve while doing surgery. My aim is to identify the trunk of facial nerve while I am doing surgery. So here the point is the trunk of facial nerve is identified by dash. That's a question. Can somebody tell me what is the answer for that? So trunk of facial nerve is identified by, how will you identify it? By Conley's pointer. What is this Conley's pointer? This question is again a repeat NEET PG question. So Conley's pointer. So when you can palpate your Conley's pointer, you just palpate your external auditory meatus. There is a cartilaginous part. When you go deeply, you can palpate the bony point. So the cartilaginous, this is a ear. This is a cartilaginous part of external auditory canal joining the bony part. This is bony part. At this point, there is a pointer. Junction of cartilaginous and bony point. There is a pointer known as tragal pointer or Conley's pointer. So the facial nerve trunk will be seen inferior to this pointer. Even if you palpate deeply, you can palpate the you can experience the pain of the facial nerve. You just keep deeply palpating there. You can press the facial nerve and you'll have pain in the facial nerve. That is a Conley's pointer. So this is a high yield MCQ for your exam. Tragal pointer or Conley's pointer is how you identify the facial nerve. It is seen 1 centimeter inferior. Very good, Rajat. Very good, Rajat. That's correct. So 1 centimeter inferior to the tragal pointer, you find out the facial nerve. You can see here an excellent dissection being done. So we have identified the facial nerve trunk, and then the branches are very safely preserved in this case. Okay. So now we are going to discuss the high yield topic in NEET PG, that is complications of parotidectomy surgery. So the most important thing I am going to discuss in parotidectomy surgery is related to the nerve injuries. Please don't forget the nerve injuries, because every year there is a question from nerve injuries during parotidectomy. What is the most common nerve injury? Can somebody tell me what is the most common nerve injured in a parotidectomy surgery? Yes? It is some branch of facial nerve. Some branch of facial nerve. Any one branch. For example, it may be a branch of facial nerve, not the main branch, main nerve. It can be a branch of marginal mandibular branch or a cervical branch. Some branch of facial nerve is the most common nerve injured in a parotidectomy surgery. Number 1. What is the most common cutaneous nerve injured? This question used to come every year. So you are doing a parotidectomy surgery and the patient develops paresthesia in the shaving area. What is a nerve injured? So it's a repeat question. You know the answer. What is it? Greater auricular nerve. Very good. Most of you are thorough with the branches. Greater auricular nerve is the most common cutaneous nerve injured. What is this Fraze syndrome? Please remember, Fraze syndrome is not a common condition. It is a very, very rare condition. It's not so commonly seen after paroidectomy surgery. It's a very rare complication. I have not seen a Fraze syndrome so far. We have done more than 25 to 30 paroidectomies, but I have not seen a Fraze syndrome so far. Fraze syndrome is due to injury of dash. Injury of auriculotemporal nerve. Injury of auriculotemporal nerve is known as facial nerve. Auriculotemporal nerve is a branch of trigeminal nerve. What is the function of this nerve? That's the important question again. So auriculotemporal nerve functions as post-ganglionic parasympathetic nerve. Please don't forget this. So injury of post-ganglionic parasympathetic nerve known as auriculotemporal nerve results in Fraze syndrome, also known as gustatory sweating. Also known as gustatory sweating. So these are high-yield clinical questions you can get in the exam after the injury of various nerves. So greater auricular nerve injury is the one which is repeatedly asked in exams as a clinical based question. A patient underwent paroidectomy, developed paresthesia in front of face is greater auricular nerve. So please remember, facial nerve is a pure motor nerve. There will be no paresthesia. Facial nerve is a pure motor nerve. There will be no paresthesia. There will be only function loss, like loss of nasolabial groove, deviation, etc., etc. So please remember this point. Okay. Yes, very good, Aryan. That's correct. It's a branch of mandibular branch of trigeminal nerve. It's a branch of, ideally to be said as, auriculotemporal nerve is a mandibular branch of trigeminal nerve, gives auriculotemporal nerve. Okay. So yes, the Fraze syndrome can be prevented by keeping a sternum-mastoid flap, but I'm not going into those details. I'm going to ask some questions from the parotid cancers. It's just like a one-liner. You should tell me. Cancer parotid gland. I'm just asking the question, you tell me the answer. Which parotid gland tumor can infiltrate to the base of skull? The parotid gland cancer which can infiltrate into the base of skull. What is it? Yes, anybody? This is one important question. Parotid gland tumor which is 10% bilateral tumor. I am asking you questions from parotid gland. The parotid gland tumor which can infiltrate to the base of skull, which is also known as perineural infiltration. What is the answer? I am expecting someone to answer because there will be a 1 minute delay. Yes, very good, Azhar, but it's not adeno cancer. What do we say it as? Adenoid cystic cancer. Okay, it is adenoid cystic cancer. No, not mucoepidermoid. Rajat. Mucoepidermoid is a cancer which produces more of lymph nodes. Lymph node mets are more common in which cancer? The answer is mucoepidermoid cancer. Which cancer is 10% bilateral? I am waiting for that answer. Which cancer is 10% bilateral? Not pleomorphic adenoma. Pleomorphic adenoma is the most common benign tumor. 10% bilateral tumor is Warthin's tumor. Which salivary gland tumor is exclusive to parotid, not seen in anywhere else? Which salivary gland tumor is exclusive to parotid, not seen anywhere else? It's seen only in parotid gland. Yes, anybody? Yes, very good, Arjun, very good. That is Warthin. Exclusive to parotid gland is Warthin's. Exclusively it is seen in parotid gland, not seen in any other glands. All salivary gland tumors are common in females. The one which is most common in males is again Warthin's. So most common in males and smokers is Warthin's tumor. So please remember, you should be thorough with the Warthin's tumor. So adenoid cystic cancer can happen in any gland. Any gland it can happen. It can happen in parotid gland. It can happen in submandibular gland also. Anywhere it can happen. The question is different. I am not asking which gland, which tumor is common. I am not going to that. I am asking what are the features of each tumor. MCQs from each tumor I am telling you here. So So Warthin's tumor is most common in male smokers and exclusive to parotid gland. It is 10% bilateral. Okay. So let us show you some images now. So what is this? There is a oral cancer operation being done. The patient had a oral cancer. For a oral cancer, reconstruction is done with a flap. What is this flap? You can see this flap arising from the deltopectoral area. From here, the flap is shifted here. What is this flap? This is deltopectoral flap. Based on which artery? Yes, internal mammary artery. This is a repeat MCQ. So there are two flaps used for oral cancer reconstruction after radical neck node dissection. After radical neck node dissection, there are two flaps used. Deltopectoral flap based on internal mammary artery, and this is the next one. This is flap taken from the chest and shifted to the oral cavity. This is PMMC flap based on thoracoacromion artery. At this point of time, I want to tell you, if you read anywhere flap, if at all you read a term flap, always remember the artery supplying the flap. All flaps will have one named artery. Will be having a named artery. They are known as axial pattern flaps. Axial pattern flaps will have a named blood supply. What is the name of the flap which will have no named blood vessel? It is known as random pattern flap. These are all plastic surgery questions. No named blood vessel will be there. Okay. So please remember, axial pattern flap will have a named blood vessel. Random pattern flap will have no named blood vessel. So this PMMC, pectoralis major myocutaneous flap, is used in males because we can shift the chest muscle from here to here. But in females, we have to go for deltopectoral flap. Otherwise, what will happen? We will be shifting the breast tissue from here to the oral cavity. So you should not use PMMC flap in females. We should use PMMC flap in males, deltopectoral flap in females. So please don't forget these two images. 100 times asked image. What is this? So RFF flap, radial forearm free flap, as I just RFF is nothing but radial forearm free flap. It is used for small defects, not for bigger defects. Small volume defects, we use RFF flap. For larger defects, we use PMMC flap. There is no question as which flap is commonly used. There is no such question for oral cancers. There will be a question, what will you use for a radical neck node dissection done? This area, how will you cover? It is by PMMC flap or deltopectoral flap. If hemiglossectomy done for the tongue, which will you use? I will use RFF flap. So in otherwise, you simply remember small volume defects, RFF flap. Big defects, we use PMMC and deltopectoral flap. Very good, Indian. That's the correct answer. This incision is high yield MCQ. This is Weber Ferguson incision. Where will you use this incision? Can you tell me where will you use this incision? For what cancer operation? Yes, what cancer operation you use this incision? This is used for heart, palate and maxilla tumors. Heart, palate tumors and maxilla tumors, we use this Weber Ferguson incision. The incision will be going along the inner surface of the eye and for face. Very good, Rajat. That's used for heart, palate and maxilla tumors. Very good. So this is a high yield MCQ, again an image based question from an angiogram. This is a carotid angiogram. Carotid angiogram showing you a picture here. You can see this is internal carotid artery. This is the external carotid artery. Internal carotid artery has no branch in the neck. You can see external carotid artery having multiple branches. What is this sign known as? Yes, what is the name of this sign? What is the name of this sign? This sign is known as a Leyer sign. Very good, Anisha, very good. That is a Leyer sign seen in chemodectoma. Chemodectoma, also known as carotid body tumor or potato tumor. So the classical examination findings, because this question can come as a clinical based question, I want to tell you two clinical findings. If there is a swelling on the neck, if I keep two fingers on the swelling like this, what pulsation will I get? If I keep two fingers like this, what pulsation will I get? I will get a, on the swelling, if I keep two fingers, I will not get expansile pulsation, I will get a transmitted pulsation. Transmitted pulsation is seen. Please don't forget this first point. So what is the pulsation seen as? Transmitted pulsation. And if you see, this is swelling, I can move it horizontally, but I cannot move it vertically. Vertical movement is not possible, but I can move it horizontally like this. So this sign is known as Fontaine sign. Fontaine sign. So the swelling is movable horizontally but not movable vertically is known as Fontaine sign. So this question, carotid body tumor, is a highly expected clinical question. Please don't forget this. So highly expected clinical question. So what are the clinical findings you should not forget in carotid body tumor? If I keep two fingers on the swelling, there will be transmitted pulsation, not expansile pulsation. It is sitting on the artery. It is not arising from the artery. If it is arising from the artery, there will be expansile pulsation. It is sitting on the artery, so there will be transmitted pulsation, and I can move the swelling horizontally like this. It cannot be moved vertically like this. So that is known as Fontaine sign. So carotid body tumor is a high yield MCQ clinical question for your exams. So next question is an interesting question from the image. This girl, if you see here very carefully in this girl, this is sternocleidomastoid muscle, this is clavicle, this is the posterior trapezius muscle. So now you can see in this triangle, there is the swelling. Can you note the swelling there? I don't know how many of you could watch the swelling there. There is the swelling here. So sternocleidomastoid, trapezius and clavicle is forming the posterior triangle in the neck. In the posterior triangle in the neck, at the base of the triangle, I am seeing a bony swelling. And the patient comes to me with the complaints of what? Intermittent claudication. When the patient starts writing or starts washing cloths, there is pain. So the patient is having a pain in the upper limb. That is known as intermittent claudication pain. Gradually, this girl has come to me with a gangrene of the fingers itself. Can you see? There is a gangrene of the fingers itself. So this is a typical picture showing you intermittent claudication pain plus gangrene of fingers plus a swelling in the base of posterior triangle. The diagnosis is cervical rib causing thoracic outlet syndrome. Please don't forget, this is cervical rib causing thoracic outlet syndrome. Very good. So in this, there are some video questions asked in every year. I am going to show you the videos of the patient. So I am going to demonstrate you the test. You should tell me what is that test. Asking the patient to extend the limb. I am turning the head to the same side, taking a deep breath, and I will palpate the radial artery. What is this test? Test number 1. I want to know if there is any occult thoracic outlet syndrome. I am going to ask the patient to extend the limb, turn the head to same side, take a deep breath, palpate the radial artery. The radial artery pulse decreases. What is this test known as? This is known as number 1, Adson's test. So I am demonstrating this test is because these test questions came in the exam last year as a video question. People all wrote wrongly. Adson test. The test which I demonstrated is Adson test. Test number 2. I am keeping the hands like this, asking the patient to keep the hands like this, right angles to each other, and keep doing like this for few minutes, like 2 to 3 minutes. Ask them to do like this continuously. The patient will have pain and will put the hands down. That is known as Roos test. That is known as Roos test. The video which came last year is this test. Ask the patient to hyperextend the arm. This should touch the ear. What is this test? Hyperextend the arm and touch the ear. The patient will have pain and will leave the hand down. That test is known as Wright test. Okay, Wright test. Wright test is hyperabduction test. Wright test is hyperabduction test. Then the fourth one is Halsted test. You should ask the patient to stand like a military man, they should stand like a military man. So like a military man they should stand with the extended shoulders, they should stand like that, they will have pain. So that is known as Alster test. So this video question came last year is on right test. Hyperabduction of the arm touching the ear will result in pain and the patient will leave the hand down. So this is typical right test. So please don't forget, cervical rib is a high yield MCQ for your exams. So thoracic outlet syndrome will result from this. So this is a direct picture. Next image is directly a picture from, we have to do surgery only. We have to do surgery to remove the cervical rib. The surgery will be done usually by cardiothoracic surgeons. They will remove the cervical rib. Then only it will be all right. Okay. So this is a picture showing you a clear-cut question directly from Bailey and Love. This is the most common site of, I am giving you the clue. Ectopic salivary gland. Most common site of ectopic salivary gland. What is this? Most common site of ectopic salivary gland is very good, Medici, very good. That is Staphney bone cyst. It is a picture directly from Bailey and Love. It is a radiolucent shadow. Radiolucent shadow at angle of mandible is known as Staphney bone cyst. It's at the angle of mandible, Staphney bone cyst. Please don't forget this image. So are you having any doubt in head and neck? Any topic you want to discuss in head and neck? Because I want to discuss this session is exclusive because more and more clinical questions they are asking. This chapter, today the discussion is more full of clinical. Head and neck, thyroid, breast, hernia, all these topics which are essential. Final MBBS topics, the examiners may be more focused on final year topics. So I am focusing today on these topics only. So especially clinical topics. So any doubt you have, you can always ask me related to oral cancer, head and neck, salivary gland tumors and neck swellings. All these topics are completed. Now we are moving on to the next essential chapter, that is on thyroid. Essential topic. National Board examiners will not have a question paper without at least 2 questions on thyroid and 2 questions on breast. There will be at least 4 questions from thyroid and breast every year. Because these are undergraduate topics, they will definitely keep you these questions. So please don't forget this. So the first question I want to ask you from thyroid is, most common site of injury of recurrent laryngeal nerve. Please answer this question. Direct line from Bailey and Love. Most common site of injury. Submandibular stone. Rajat, you want to discuss about submandibular stone. A few points about submandibular stone. The concept of submandibular duct stone is completely changed now. So this is a submandibular duct. So this is a submandibular duct. 3 mm stones. 3 mm stones in the duct. 3 mm, less than 3 mm stones in the duct can be removed by Darmia basket by entering through the submandibular duct. Through this we can put a, I hope you know where is the submandibular duct. That is nothing but Wharton's duct. You just lift the tongue, you can see the duct there. Through that you cannulate a small scopy and you can push a Darmia basket and remove the stone. Less than 3 mm stones can be removed by Darmia basket. More than 3 mm stones need what? We need lithotripter and remove. With the lithotripter you break it and remove it. That's the answer. That is the answer. Lithotripter and remove for more than 3 mm stones. Stones inside the glands. Excise the gland. So this is the latest concept. Previously there are many controversy. Nothing is there now. Less than 3 mm stone, Darmia basket. More than 3 mm stone, lithotripter and remove. Excise the gland if the stone is inside the submandibular gland. Okay. You can 3 mm to 4 mm. Actually, it's not a specific size. I feel if you remember as 3 mm, it's fine. I think 3 mm or 4 mm. I am not sure with the correct millimeter. But very small stones you can be removed by Darmia basket. More than 3 mm stones should be removed by lithotripter. Plunging ranula is a retention cyst. Plunging ranula is a retention cyst of submandibular gland. So the treatment is excise the submandibular gland. That's the answer. Excise the submandibular gland is the correct answer of plunging granula. Plunging granula, we have to excise the submandibular gland. Okay. So let us go to thyroid now. Yes, very good. Most of you have answered it very correctly. Rajat is correct. Anmol is correct. There are many more triangles mentioned in many ENT books, but I don't know other triangles like riddles, etc. Only one triangle I know which is there in Bailey and Love, that is Beer's triangle. It's a definite MCQ for your exam. Yes, as you are telling, there are many triangles mentioned in ENT MCQ books. But for me, the exam point which you should remember is Beer's triangle is the most common site of recurrent laryngeal nerve injury. It is bounded by the following three structures. That's a structure of common carotid artery. This is common carotid artery. Common carotid artery. You can see the inferior thyroid artery and the tracheoesophageal groove. So this is a triangle, Beer's triangle. So you can see inferior thyroid artery, tracheoesophageal groove and common carotid artery. In this, the lateral border is formed by, in the lateral border you can see the nerve running on the lateral border, sorry, on the medial border. So on the medial border the nerve is formed. That is the most common site of injury of recurrent laryngeal nerve. So what is Zucker-Cantel, tubercle of Zucker-Cantel? What is the significance of this? This question is also, all these are taken only from Bailey and Love. Tubercle of Zucker-Cantel is the most posterolateral. So this is a gland. Anteriorly I am seeing the gland. If I go posteriorly, the posterolateral, this is a posterolateral. When you dissect it, the posterolateral part of the gland will be pointing towards, that gland will be pointing towards, the pointing tip to recurrent laryngeal nerve. That is known as tubercle of Zucker-Cantel, the posterolateral, no confusion in this. The nerve will be normally lying posterolaterally. When I am mobilizing, it will be lying posterolateral part of the gland called tubercle of Zucker-Cantel. This question is expected from anatomy part of Bailey and Love. So now I am going to discuss few points about this scan. Radioactive iodine uptake study. So you all know very well, thyroid gland takes up iodine. When I give radioactive iodine, it will take up full radioactive iodine. Iodine 131 and 123 are the two radioactive iodine substances I use in practice. Iodine 131 is having a half-life of 8 days. 123 has an half-life of 12 to 14 hours only. Therefore, iodine 123 is used for a diagnostic purpose. Iodine 131 is used for therapeutic purpose. So only two substances are commonly used in practice, 131 and 123. Iodine 131 is used for therapeutic purpose, 123 is used for a diagnostic purpose. Please don't forget this basic point. 123 is having a 12 to 14 hours half-life. Let me tell you the diagnostic uses. I am showing you all the diagnostic uses in the image. The first image is showing you there is a nodule. After giving radioactive iodine, I am going to use a gamma camera to scan the thyroid, and I am going to show you the picture. This is the picture showing you the thyroid. Yes, when I am using therapeutically, I have to isolate the patient. No doubt, okay. I have to isolate the patient when I am using therapeutically. Not needed for diagnostic. It's a very small dose. Nothing to worry about in diagnostic. So cold nodule and this is warm nodule. The old concept of hot nodule is no more. It is warm nodule 5% malignancy. Cold nodule is 20% malignant. So we can find out whether the nodule is hot, warm or cold. And we can find out whether it is a Graves' disease. Graves' disease will have increased activity than the increased uptake will be seen in Graves' disease. Toxic nodular goiter, you can see more hot nodules. And in thyroiditis, you can see interesting point, there will be decreased uptake. So these are the various uses. I can find out whether it is a hot nodule, I can find out it is a cold nodule, I can find out it is a hyperthyroidism or hypothyroidism, I can find out whether it is a, where is the ectopic thyroid also I can find out. Please remember, I can also find out ectopic thyroid. Ectopic thyroid can also be identified with the help of this radioactive iodine uptake study. Apart from that, though these are all theory, the most important use is what? Can anybody tell me what is the most important use? Yes, Shambhavi, welcome. You are delayed for the class today. So, Dr. Shi, the isolation is because it is carcinogenic. Iodine 131 is carcinogenic. If you are going to get exposed to the person who is having a radioactive iodine consumption, you will get hypothyroidism. You will get hypothyroidism because of the radiation exposure. So please remember, it is like a radiation exposure. Iodine 131 is a radiation exposure. We should be very far away. Okay, we should be very far away. Okay, Jitesh. I think some places I am going without my knowledge outside. Okay. So this point you should not forget. Okay, this point you should not forget. The most important use of iodine 123 is to diagnose the METs. Can you see? I am diagnosing the METs here. After surgery, after follicular cancer and papillary cancer operations, what surgery I do for them? I will do total thyroidectomy for them. After total thyroidectomy for papillary and follicular cancer, I should do radioactive iodine uptake to look for the functioning metastasis. You can see the METs. Patient is having everywhere METs. These are the main use of this. Once I diagnose the METs, now I will give iodine 131 as an ablation. This will go and ablate all the METs. Iodine 131 ablative therapy is given for ablation of the METs. It is mainly done for differentiated thyroid cancers only, like follicular and papillary. This type of radioactive iodine uptake study is not useful for medullary cancer, not useful for anaplastic cancer. Only for the common two cancers, that is follicular and papillary, we use this. So to diagnose the METs and to ablate the METs. So please don't forget, the gold standard treatment for Graves' disease is what? It is also radioactive iodine uptake. Radioactive iodine 131 is the answer for Graves' disease. Also the treatment is iodine 131. Okay, so please don't forget these points from radioactive iodine 131. And whenever the examiner wants to ask some questions from thyroid, they always ask clinical examination of thyroid in the exam. Okay, what is the name of this test? So iodine 123 is a diagnostic, so don't get confused with it. Within 12 hours it will be excreted. Iodine 31 is a therapeutic. So there is no such gap between thyroid scan and surgery. There is no such question. There is no need of such type of points. You are getting confused between some other question. There is no such gap between surgery and scan. Okay, there is no such question. Yes, now tell me the test I am showing you here. What is this test? This is a Pemberton sign. It is indicated if lower border of thyroid is not visible. If lower border is not visible, then only I will do this Pemberton sign to look out retrosternal extension. No, wrong. It is not to look only for retrosternal extension. It is not for retrosternal extension. What is the reason I am doing this? It is done to look for retrosternal extension compressing the superior vena cava. SVC compression. It will go and compress the SVC. SVC compression can happen. So if it compresses the SVC, there will be facial puffiness and dilated veins. Dilated veins. So please remember that. Rajat, no need to remember all the signs. I am telling you only 5 signs you remember for eye signs. Only 5 signs. Don't keep on reading all the signs given in all the books. There are 15-20 signs given in some textbooks. They are all not needed. So what you should remember is Van Graaffie. When you read itself, you should remember like this. Van Graaffie's Lidlac sign. When you read itself, you read like that. Van Graaffie's Lidlac sign. See, ask the patient to keep the hand like, keep a finger like this. Ask the patient to follow continuously. When the patient is following, there will be a lid lag, that is known as Von Graffi sign. Von Graffi is lid lag sign. Von Graffi is lid lag sign. So now fix the head, ask the patient to see the ceiling. Fix the head, ask the patient to see the ceiling. If I am seeing, I am getting wrinkles. These patients have exophthalmos, they will just like that see the ceiling. That is Geoffroy's absent wrinkle sign. You read like this, Geoffroy's absent wrinkle sign. Don't read Geoffroy's means absent wrinkle. Don't read like that. Geoffroy's absent wrinkle sign. You read like that. Von Graffi's lid lag sign. Stellwachs staring look. You remember Stellwach will have a staring look. Stellwachs staring look sign. Okay, Dalrymple. The Dalrymple is, if you see my eyes, you can see my lower sclera is visible. Am I audible? Checking. Hello. So am I audible? Okay, thanks. Sorry, I thought I was suddenly had a stuck up. So please remember Von Graffi's lid lag sign, Geoffroy's absent wrinkle sign, Stellwach's staring look sign. So Stellwach's staring look sign. I am having in another system, suddenly it got stuck up in another system. That's why. So Stellwach's staring look sign. So in which sign will I see the upper sclera? Instead of lower sclera, I will see the upper sclera. Dalrymple. Upper sclera sign. Remember like that. Upper sclera is nothing but lid retraction sign. Because of the lid retraction, I am seeing the upper lid. Upper lid retraction. I am seeing the upper sclera. That is Dalrymple. Then the last sign you should remember is Mobius. Mobius absent convergence sign. That's all. These 5 signs enough for you. For your exam, these 5 signs are enough for exams. These are the 5 signs from Das. Clinical case Das. Don't waste your time reading unnecessary signs. So Von Graffi's lid lag, Geoffroy's absent, wrinkle, and Stellwach's staring look, Dalrymple's visible upper sclera, Mobius absent convergence sign. These are the signs you must not forget for your exams. Okay, you must not forget these signs for your exams. Is it clear? Okay. So now let us go to the next test. What is this? Always remember, thyroid should be palpated from behind. As I am examining here, thyroid should be palpated from behind. This test is done for short neck individuals. What is the name of this test? For short neck individuals, we do this test. This test is known as Picillo's test. To examine the thyroid gland, we put the patient in hyperextension by clasping the hands behind. So these are the 2 classical videos which came last year. 2 video questions. In the first, actually the first test, I am pushing with my 3 fingers and palpating with the other 3 fingers. What is this sign? This sign is known as, test is known as Lahey's test. So the second test, you see, I am just palpating with the thumb and asking the patient to swallow. For a doubtful nodule, I can palpate with this. This is known as, so thyroid examination test will be asked in your exam. So please don't forget those questions. Examining with the 3 fingers is Lahey's. Examining with the thumb is Kreil's. Yes, very good. So please don't forget these 2 tests. So I used to remember, don't get confused, Lahey's and Kreil's during the exam. So remember, if I keep my thumb like this, it looks like a C. So it is a Kreil's test. And the exam, what happens now, students finally during the exam time, they get confused between Lahey's and Kreil's. Kreil is thumb. Lahey's is 3 fingers. Okay, 3 fingers. Or even the 4 fingers you can use. So this is a thyroglossal cyst which moves with the protrusion of tongue. I want to ask 3 questions from thyroglossal cyst. The only swelling moving with the protrusion of tongue is thyroglossal cyst. What cancer which can arise from this thyroglossal cyst? That is my one question. What is the cancer which can arise from this cyst? Yes? Papillary cancer can arise from this cyst. So please don't forget, papillary cancer can arise from this cyst. Papillary cancer can arise from this. Okay, very good Arjun, very good. The next question, thyroglossal cyst. It is operated by cyst trunk surgery. Everyone knows that. Everyone knows it is cyst trunk operation done for this thyroglossal cyst. In cyst trunk operation, the classical point you should not forget is this is hyoid bone. What is cut in the hyoid bone? Cyst trunk operation means we have to cut the hyoid bone along with the tract of the thyroglossal cyst. Along with the tract of the thyroglossal cyst, I have to cut the hyoid bone. The question is, will you remove the full hyoid bone, or lateral portion, or central portion of the hyoid bone? Answer is, I should cut the central part of hyoid bone. In cyst trunk operation, I will cut the central part of hyoid bone. So central part of hyoid bone should be cut. That only is known as cyst trunk. If you don't cut the central part of hyoid bone, it is not known as cyst trunk at all. So cyst trunk operation, the central part of hyoid bone should be cut. Okay. So this is a pathology question you will be answering immediately. So this is a picture showing you orphan eye nuclei, and this is psammoma bodies. So therefore this is a papillary cancer. Yes, very good Simran, that is correct. We have to remove it from the central full tract, we have to remove including the central part of hyoid bone. So this is papillary cancer. Now let us have some questions from papillary cancer. Papillary cancer is the most common cancer. You all know very well it is the most common thyroid cancer. The cancer with the best prognosis is papillary cancer. There will be always a fascinating question when you are going to get a curse from someone. Someone is cursing you, you are going to get a cancer and die. Which cancer you prefer to get? The cancer we should prefer to get is a papillary cancer. The cancer which will never cause a death at all. They will be living normal life after operation. So papillary cancer is having such a good prognosis and excellent prognosis. If you are going to get a curse of getting a cancer, you should opt for a papillary cancer than any other cancer. That much it is having a best prognosis. So papillary cancer spreads by lymph node mets, and one such lymph node mets is known as lateral aberrant thyroid. So please don't forget, lateral aberrant thyroid is a misnomer. It is a metastatic node from non-palpable papillary cancer. So lateral aberrant thyroid is a metastatic node from a non-palpable papillary cancer is known as lateral aberrant thyroid. So please don't forget, lateral aberrant thyroid is a high yield MCQ for your exams. So papillary cancer is caused by 3 factors. Yes, very good Azhar, that's correct. One is lymphoma, non-Hodgkin's lymphoma, not Hodgkin's. It is not Hodgkin's, it is non-Hodgkin's lymphoma. Actually we should not say it as non-Hodgkin's. We should tell 3 causes of papillary cancer are: first important cause is irradiation. Even those guys who had radioactive iodine ablation, they can get papillary cancer. Radioactive iodine ablation, they can develop papillary cancer. Hashimoto's can cause non-Hodgkin's lymphoma and papillary cancer. And very important, as you are telling, that is associated with irradiation, Hashimoto's and thyroglossal cyst. These are the 3 causes of papillary cancer. Why will you get a papillary cancer is irradiation, Hashimoto's, thyroglossal cyst. Okay, papillary cancer is a cancer which is TSH dependent. I don't know how many of you know this point. It is TSH dependent cancer. In otherwise, if TSH increases, cancer grows. If TSH increases, cancer grows. Therefore, after surgery, what I will do is I will give TSH suppression therapy, that is triple dose thyroxine given. So all papillary cancer patients who are operated, we will be giving triple dose thyroxine. Triple dose thyroxine will be given for those guys to suppress the cancer being happening again. So triple dose thyroxine should be given, like 0.3 milligram we used to give for those guys. Okay. So long-standing multinodular cancer, long-standing multinodular goiter like this is developing a cancer. What do you think this cancer will be? A long-standing multinodular goiter developing a cancer. Yes, very good, Joseph. All your points are correct. This is long-standing multinodular goiter. So regarding the pathology questions, I am not sure with Azhar. You should confirm with the pathologist. But what is there in Bayesian law I am taking here? So what is this? What is this long-standing goiter? Very good, Rajat. That is a follicular cancer. Follicular cancer produces more of hematogenous mets. They produce pulsatile skull secondaries. They produce pulsatile skull secondaries. Very important thing. They produce pulsatile skull secondaries. They are osteolytic in nature. What is the tumor marker for these two cancers? These two are well differentiated cancers. We have a tumor marker. What is it? The tumor marker is thyroglobulin. Thyroglobulin is a tumor marker for papillary and follicular cancer. For papillary and follicular cancer, the tumor marker used is thyroglobulin. You can see an osteolytic skull secondary in case of follicular cancer. So where will you get amyloid stroma on FNAC? Fine needle aspiration cytology shows amyloid stroma. What is the condition? It is medullary cancer thyroid. There are two tumor markers for this. Follow-up is done with the help of calcitonin, and prognosis is decided with the help of CEA. There are two tumor markers for medullary cancer. Please don't forget this. So FNAC shows amyloid stroma is a medullary cancer. So 20% of them can be familial, running with the help of MEN2A syndromes. MEN2A 2B syndrome will be running in medullary cancer in 20%, not majority. 80% are sporadic only. Please remember, medullary cancers 80% are sporadic, only 20% will have familial MEN2A, MEN2B syndromes. MEN2A, MEN2B syndromes, we should rule out another important cancer before surgery, that is what? I should rule out pheochromocytoma. Pakka clinical question. This question is a Pakka clinical question. We should rule out pheochromocytoma before operating a medullary cancer, and we have to exclude it before surgery. And if it is a MEN2A, we should do a prophylactic thyroidectomy. When it is a MEN2A syndrome, it should be done before 5 years, and when it is a 2B syndrome, it should be done before 1 year. MEN2B is more aggressive than MEN2A. When you see a patient with a MEN2A or MEN2B, we should do prophylactic thyroidectomy before 5 years for MEN2A and before 1 year for MEN2B. Yes, we have to rule out urinary VMA, plasma metanephrin, everything should be measured to rule out pheochromocytoma. Okay, so MEN2A patient should be operated for thyroidectomy before 5 years. 2B is more aggressive, you should do thyroidectomy before 1 year. Okay. So some of you asked the doubt in the beginning itself. So this is from Bayesian law. What is there in Bayesian law is this. Lobectomy means we remove one gland along with the isthmus. It was the old name known as hemithyroidectomy. Many points will be wrong in Bayesian law, but examiners will not know that. You have to follow blindly what is there in Bayesian law. That is, such one point as subtotal thyroidectomy is leaving 8 grams of tissue on both sides. A direct line from Bayesian law. a direct line from Bailian law. Leaving 8 gram of tissue on this tracheoesophageal groove, another 8 gram of tissue in this 8 gram is known as subtotal thoracotomy. There is still near total thoracotomy mentioned in Bailian law. What is near total? It is 2 to 4 gram tissue left on one side only. That surgery is known as Dunhill operation. 2 to 4 gram left on one side is known as Dunhill operation. Please don't forget this. Dunhill operation is 2 to 4 gram of tissue left on one side. It is known as Dunhill operation. Okay. So subtotal thoracotomy 8 gram left on both sides. Near total 2 to 4 gram left on one side. So lobectomy is removal of the gland. So while doing thoracotomy, certain essential questions I want you to remember here. What is the position you should put the patient while doing surgery for thyroid? Position. Yes. That is known as dog bark position. It is not rose position. It is not the typical rose position. We call the rose position for tonsil operation, but this is dog bark. We put the patient in this position, extended neck with a sandbag under the shoulder. The neck should be fully extended so that the thyroid gland can be easily exposed. Okay, superior thyroid artery is ligated close to the gland or away from the gland. Inferior thyroid artery ligated close to the gland or away from the gland. Can you tell me the answer for these two questions? When I am doing surgery, yes, very good, Sivagita, that is another term you can use. Superior thyroid artery is ligated close to the gland. Inferior thyroid artery is also ligated close to the gland. Old concept is inferior thyroid artery ligated away from the gland. This concept is no more. Now the latest concept is both are ligated close to the gland. Why inferior thyroid artery is ligated close to the gland? Because this is the gland, means the inferior thyroid artery gives branches to parathyroid like this. This is the parathyroid branch. If I ligate it very far away, I damage the parathyroid blood supply also. So I should ligate it very close to the gland. The parathyroid supply will not be damaged. So both should be ligated close to the gland. Most common nerve injured, what is it? In thyroid surgery, most common nerve injured is what? Yes, what is the most common nerve injured in thyroid surgery? Anybody? The external laryngeal nerve. Many of them are thinking as recurrent laryngeal nerve. It is wrong. The external laryngeal nerve is the most common nerve injured. Recurrent laryngeal nerve can get injured. If single nerve is recurrent laryngeal nerve is injured, it is hoarseness of voice. If bilaterally injured, it results in stridor. You would have been reading this type of points more better in ENT. So please remember, the most common nerve injured is external laryngeal nerve. Single nerve injury of external recurrent laryngeal nerve causes hoarseness. Bilateral causes stridor. Okay. So this is a very commonly asked clinical question. Once upon a time, you are a house surgeon, you are going for a ward rounds. While going for a ward rounds, you are seeing the patient who operated for thyroidectomy in the morning now having tachypnea, and you are seeing a huge hematoma. What will you do immediately? I will let out the hematoma immediately on the bedside itself by removing the sutures and shift to OT. This complication will not be asked hereafter, because now latest concept is, while we are doing thyroid surgery, we keep a drain now in the thyroid area. For how many hours you should keep the drain? So drain is kept in the thyroid operated area for how many hours? It's kept for 24 hours. Drain is kept. So near exam, 3 or 4 days before the exam, I am going to discuss certain things which are needed for essential last minute, like named operations, instruments, signs, all those things I am going to discuss near the exam, so that will be helpful for you. But otherwise, those who are new to this QRP session, So already all these QRP sessions are available in my YouTube channel as well as in Doc Tutorial app also. All these are available. So this is a live session. Actually we are doing a live session to clear your doubts. Otherwise most of them are available already in my YouTube channel as well as in Doc Tutorials platform. Also it's available, so you can utilize them. So 24 hours drain is kept nowadays, so no need of this question hereafter. If there is a bleeding going to come, it will get collected in the drain. Okay, that will be collected in the drain. So you are a senior resident going for rounds on the third post-op day. At the time your junior resident is measuring the blood pressure. At that time you are seeing the thyroidectomy done patient is having a sign like this. What is this sign? It is known as Trousseau sign. Immediately you tap in front of the ear, there is a Choustuck sign. These two signs are signs of occult hypocalcemia. Please don't forget, it is not overt hypocalcemia. These two are signs of occult hypocalcemia, usually due to loss of blood supply. It is not due to removal of parathyroid gland. It is usually due to loss of blood supply to the parathyroid gland. The patient develops occult hypocalcemia. When you go and read SWOTs, in SWOTs they say occult hypocalcemia, we can give oral calcium is enough. If the patient is having tetany, I hope you know tetany, but the patient will be lying in an opisthotonus position in the ward. When you go to the patient will be lying in opisthotonus, you have to give injection calcium. So overt cases we have to give injection calcium gluconate. Occult cases oral calcium gluconate is enough. This is a concept from SWOTs, not mentioned in Bailey. Bailey says IV calcium, that's all. But SWOTs gives clear-cut point. Trousseau sign and Choustuck sign are seen means you can give oral calcium and observe. Okay. So these are the essential points I wanted you to know from thyroid gland. You have any doubts in thyroid gland, please tell me, because I am next moving on to the cancer breast topic. So this is today's topic is fully clinical based topics for final MBBS students I am discussing today. Any doubt you have in thyroid topic, please tell me. Any doubts you have in thyroid related topics, please tell me. Or else we'll move on to the cancer breast. Yes, any doubts you have? Yes, hydration is a part of any patient. So IV fluid will be pushed on and we have to give IV calcium gluconate. So yes, we will move on to the next topic. If you have any doubt, you can tell me in a thyroid. Meanwhile, I will be discussing cancer breast. So this is a patient coming to you with a cancer breast. Patient, I am going to ask you the staging for this case. Patient is having a 4 centimeter cancer in upper outer quadrant. Upper outer quadrant, there is a 4 centimeter lesion. And you can see there is some finding in the breast. What is the T staging of this case? So that is why should you need a Tariq Siddiq for a pneumonic for Wolf and George Besidos. George Besidos thyrotoxicosis is due to, you need not get confused at all. George Besido is toxicosis. George Besido means what? It is a toxicosis. Due to excess iodine. What happens? No, some girls come to our clinic. We will tell them some girls will have depression, they are obese. You tell them you are obese because of hypothyroidism only. Once you consume iodide, you will become normal soon. They will start consuming more and more iodide. That is George Besidos that results in toxicosis. The same excess iodide consumption causing toxicosis is known as George Besidos toxicosis. It can sometimes cause a rebound inhibition of thyroxine production. That is known as Wolff-Chaikoff effect. Wolff-Chaikoff effect is hypothyroidism. Please don't forget, it is hypothyroidism. George Besido is hyperthyroidism. Okay, please don't forget this. Yes, for you, Joseph is giving a mnemonic. Joseph is telling Chaikoff means hypothyroidism. Okay, you can remember that. So usually surgery doesn't need mnemonic because surgery is not such a subject to mug up at all. Surgery is a subject to understand and you can experience and you can live with it. So remembering mnemonics is not at all needed for surgery. You can use mnemonics for basic science subjects, etc. But for surgery, I feel surgery itself is such a subject which which doesn't need a mnemonic at all. Everything you can understand when you read and understand, and you can see a few patients you see, you will never forget any of these points. Okay. Ajit Sharma, I don't know what you are asking for flap. Axial pattern flap is a flap containing named blood vessel. Random flap will not have named blood vessel. That's all. Only two flaps. So any specific flaps you should see from pediatrics, from plastic topic, you will be seeing the flaps. So this is a 4 centimeter tumor and that is Peau d'Orange scene. What do you think? What do you think will be the staging? I will tell you, this is T4B. What is T4B? That is skin changes are present. Skin involvement in a cancer breast is known as Peau d'Orange. What else? Ulceration, satellite nodules. All this will come under T staging. T4B. No, I am not asking T4. I am asking T4B or A. This is T4B. So next question, the patient is having a tumor fixed to the chest wall. You can see the tumor is fixed to the chest wall. That is the ribs. What do you say this as? T4A. Chest wall fixity. Like ribs, intercostal muscles, serratus anterior muscle. It should not include what? T4A does not include dash. T4A does not include pectoralis fixity. Pectoralis major will not come under T4A. Very important point I want you to remember. T4A means the tumor getting fixed to the chest wall, intercostal muscle and serratus anterior muscle, not with pectoralis major at all. Thyroidectomy, just now we discussed Asiya Naik. You can just go back and see the video after the class. It's already recorded. So pectoralis major muscle is not included in T4A. Pectoralis major or pectoralis minor, both are not included. Similarly, T4B does not include what? Not includes fixity, dimpling, puckering. None of them are included in this. So T4B does not include fixity, dimpling, puckering. T4A does not include pectoralis major fixity. Please don't forget these points. Very essential for your exams. So this is a picture showing you a mammography. All about mammography I am going to tell you now. All about mammography. Everything about mammography. Any doubts you have in mammography, you can get it cleared here. Mammography showing you microcalcification is shown in this picture. Mammography is giving an exposure of 0.1 centigrade, which is equal to 4 X-ray chest. It is a low voltage, high amplitude X-ray. It is nothing but an X-ray. It is a low voltage, high amplitude. Pectoralis major should not be included, Ajay. It is not a part of staging at all. Pectoralis major is a base of the breast. So it doesn't include that at all in staging. So low voltage, high amplitude X-ray is known as mammography. It is a mammography. Yes, I will tell about it. Don't worry, Ajit. It is taken in two views. Craniocaudal view, mediolateral oblique view. It is done for both breast. It is always done for both breasts. We don't do for only one breast. It is done for both breasts. It is done in craniocaudal view, mediolateral oblique view. So what are the findings you get? The most common finding is microcalcification. Microcalcification is a feature of ductal cancer in situ as well as ductal cancer. Microcalcification is seen in both ductal cancer in situ as well as for ductal cancer in a mammography. Mammography is a screening investigation for females in Western countries. Screening investigation of choice in females in Western countries is mammography. It is done at or above 40 years. Mammography is the screening investigation of choice for all females above 40 years must undergo mammography in Western countries. High risk patients should undergo. High risk cases should undergo MRI. High risk patients who are having family history of breast cancer, BRCA1, BRCA2 mutation, all those cases will undergo MRI. I am not going to MRI now, but for regular people they should undergo mammography at age above 40 years. High risk cases should undergo screening from 30 years onwards. High risk cases screening starts at 30 years. Regular patient screening starts at 40 years. So I want to tell you certain MCQs. Popcorn calcification, who will get? It is fibroadenoma. Neighboring calcification, where will you get? There will be a lesion, but there will be calcification in the neighboring area. Neighboring calcification. Seen in lobular cancer. It is seen in lobular cancer. Lobular cancer. India, there is no such guideline at all. Ajit Sharma, India, we don't do screening at all. We do screening only for CA cervix, not for breast. It has to be started. So these are the points you should not forget about the mammography. Mammography is a high yield point, and this is a picture showing you an MRI. Very important indication of MRI in Western countries is this. What is this? When we are doing for a screening of the breast, having silicone implants, females having silicone implants, to rule out cancer we have to do MRI only. Silicone implanted females, we have to do MRI. One such MRI finding is this. What is this? What is this? This is a finding seen in MRI. What is it? There is a floating membrane in the silicone implant. What is it? Linguini sign. It is nothing but ruptured silicone. Rupture of silicone implant looks like a Linguini sign. Okay, Linguini sign. Ultrasound is used for females less than 35 years. For females less than 35 years, we should use ultrasound. For above 35 years, we should use mammography. Okay, so don't get confused. Indications of mammography and screening from mammography. Mammography is done for females above 35 years. Screening mammography done from age above 40 years. These two questions usually students get confused. Ultrasound is used for examining the breast less than 35 years. Mammography for above 35 years. Screening mammography for females above 40 years to look for cancer. Okay, to look for cancer. Okay. Ajit Sharma, this is silicon is not a metal. Silicon is different. I think you should know what is silicon. Silicon is not a metal. It's for a silicon implanted patients. We have to do this. Okay, to look for the cancer. If there is any cancer arising, we can find out only with the MRI in these type of patients. Okay. So now coming to BIRAT staging, breast imaging reporting and data system. Breast imaging reporting and data system. So in this I want to tell you, this is based on mammography finding only. Mammography is based on, BIRATS is based on mammography finding only, and the only question they will ask you is BIRATS 4, what will you do? BIRATS 4, what will you do? Until BIRATS 3, no biopsy needed. BIRATS 4 and above, biopsy must. Because BIRATS 4 is suspicious of malignancy. BIRATS 4 is suspicious of malignancy and we have to do biopsy. Sunaina Shaikh, I don't know about intracapsular and extracapsular rupture of silicon, but I don't have an idea about it. We will see. Only it's an intracapsular rupture only will have this Linguini sign. Extracapsular rupture and all I have not seen. So that is not asked in MCQ. So please don't worry about it. So 4 and above we should do biopsy. 4 and above we should do biopsy. Until 3 you can see there is no biopsy done. Okay, that is the point I want you to remember. This is the only question that will come from BIRATS. breast imaging, reporting and data system. And this is a core cut biopsy needle. This question can come for an exam. We use 16 gauge or 18 gauge needle for taking a core cut biopsy. Core cut biopsy is the investigation of choice to diagnose cancer breast. This is a direct question. Investigation of choice. There is a lump. I want to know it is a cancer breast. What should be the best? The best to diagnose cancer breast is by means of core cut biopsy. 16 gauge or 18 gauge needle is done. Using this needle, we will take a biopsy. And one such biopsy taken, one interesting finding is there. What is this? I have taken a biopsy from the breast and I am seeing the cells like this. What is this? Yes, what is this biopsy pattern showing you? This is a Indian file pattern of arrangement of cells seen in dash. FNAC is a 22 gauge needle. Your syringe, your 22 gauge needle is FNAC. It can diagnose cancer, but it is not the investigation of choice. 22 gauge needle is nothing but normal syringe. True cut biopsy needle, we have to put local anesthesia. Before taking a true cut biopsy needle, we have to put local anesthesia in the skin. FNAC, we don't put local anesthesia. We will just take that poke inside. Okay. So, this is an Indian file pattern seen in lobular cancer. It's not lobular cancer in situ. It is lobular invasive cancer. Invasive lobular cancer will have Indian file pattern. Interesting point about invasive lobular cancer is it is always bilateral. It is multicentric. So, invasive lobular cancer is bilateral, multicentric, multifocal. So, it is multicentric, multifocal, bilateral. What is this multifocal and multicentric? Every time the students gets confused with this. So, the center is what? Center is nipple. Around the nipple, if you get many cancer, it is multicentric. Center, there is nipple. Around the center of nipple, if you get cancer, it is multicentric. This is multicentric. In one quadrant of the breast, if you get cancer, it is focal cancer, multifocal. Many cancer in one quadrant is multifocal. Multicentric is all quadrants. Okay, please don't forget this point. So, this is very important point for your exams, essential for your exams. Okay. So, multicentric and multifocal. Sure, Ajit Sharma, that is instruments. I will be having a separate session just 3 days before exam for 1 hour. At that time, I will show you the named surgeries and all. Okay. So, now there is a very important question which is frequently asked nowadays from molecular classification of breast. This is not there in Bailey or Sabiston, but you should remember this. This is from pathology. The tumor we have taken out, the biopsy tissue from the true cut biopsy, we have to send it for biopsy. The biopsy shows immunohistochemistry should be done from the tumor. Immunohistochemistry shows estrogen receptor positive or negative, progesterone receptor positive or negative, and similarly HER2 will be shown as positive or negative. The problem is HER2 result is obtained as 0, +1, +2, +3. This is the result of HER2. They don't give as positive or negative. We will consider 0 and +1 as negative. We will consider +3 as positive. And this +2 is an equivocal. It's an equivocal. So, estrogen receptor will be given as positive or negative, progesterone given as positive or negative, HER2 will be given as 0 and +1 or +3. So, +1 we can say it as negative, +3 we can say it as positive, but for +2 equivocal, what I should do is I should do FISH, fluorescent in situ hybridization, to confirm HER2 status. Now I have done the 3 tumor markers. Very good, Simran, very good, Jack. That is 2 and above. For +2 we have to do FISH and confirm it. Now we have to confirm the types. Luminal A type is the most common type. Luminal A is the most common and the best type. So you should never forget this if you forget any other type also. But you will not forget other types. I will tell you easy method to remember them. Luminal A is estrogen receptor positive, progesterone receptor positive, HER2 negative. Simple. Luminal A type. Luminal B type. You will never forget B type, because if you are a B, you should be B positive for all. B positive. All are positive. ER positive, PR positive, HER2 positive. The next type is a basal fellow. If you are a basal fellow, you will be always negative, negative, negative. All are negative. That is basal type. B positive. All are positive in B type. In basal type, all are negative. Luminal A type is the most common type. Only HER2 is negative. And there is last type known as HER2 type. HER2 alone is positive. HER2 is positive. All ER and PR are negative. This worst fellow in this is whom? Who is the worst fellow? The basal type is the worst prognosis. Basal type is associated with which mutation? That's an expected MCQ. Basal type is associated with BRCA1. BRCA1 mutation. Please don't forget, BRCA1 mutation will have basal type cancer. So it's triple negative. BRCA1 is triple negative. Worst prognosis, 17q mutation. That is basal type cancer. Okay, basal type cancer, BRCA1 mutation, 17q mutation, triple negative. So please don't forget this molecular classification of breast cancer. So worst prognosis is seen with all negative associated with BRCA1. So BRCA1 is 17q mutation. BRCA2 is 13q mutation. You can get few questions from this also. What is the second most common cancer in these two? In BRCA1 and BRCA2, what is the second common cancer? Ovarian cancer. So first cancer is cancer breast. Second cancer is ovarian cancer. BRCA1 has 60% breast cancer, 40% ovarian cancer. BRCA2 has 80% breast cancer, 20% ovarian cancer. Yes, we have to do for all cancers who are, we can also do Ki67 index. I am not going into them details because they will be discussed in pathology. In surgery, we don't deal with them. So Ki67 index, everything will be discussed in pathology. But please remember, BRCA1 60, 40, 80, 20 for BRCA2 mutation, and male breast cancer is seen associated with BRCA2. Associated with BRCA2 mutation. So this question came as an image based question in the exam. So can you tell me what procedure is going on here? Same question came in the exam. There is a picture showing you sentinel node biopsy. In this picture, the surgeon has injected radio labeled colloid. Colloid is injected, and with a gamma camera, what he is holding in his hand is gamma camera. He is looking for hyperactive node. To send for sentinel node biopsy. That hyperactive node will be taken up and sent for sentinel node biopsy. This is not methylene blue test. In India, we don't do this test mostly. In India, we mostly do sentinel blue with the methylene blue test only. The tumor area, we will inject methylene blue, we will take the blue color node. So this is a methylene blue test. India, we mostly do this only in government hospitals. But in Western countries and many corporate hospitals, this is done with the help of gamma camera. Both are familiar only. BRCA1, BRCA2, both are familial. Both of them need prophylactic mastectomy. In the young age itself, they should undergo prophylactic mastectomy. So sentinel node biopsy image based question is asked in the exam. Please don't forget this. This is a picture showing you a specimens of modified radical mastectomy. The same image is coming again. This is a modified radical mastectomy. Modified radical mastectomy I am going to explain now. While doing modified radical mastectomy, what are the structures removed? While doing modified radical mastectomy, what are the structures removed? We remove the nipple, areola, we put a elliptical incision and remove the breast tissue. Nipple, areola, entire breast tissue along with the tumor, entire breast tissue along with the tumor. So nipple, areola, breast tissue, tumor. In BRCA, pancreatic cancer percentage, pancreatic cancer is associated in 5 to 10%. In BRCA2, not with 1, BRCA2 it will be associated with 5 to 10%. So we are discussing MRM now. I will tell you all the things. So the incision made is known as Stewart incision. Very good. That's a elliptical Stewart incision made. I am removing the nipple, areola, breast tissue, tumor, and a elliptical shaped skin is also removed. Along with the tumor, I will also remove the pectoralis fascia, not the muscle. Please remember, I am not removing the muscle. I am removing the pectoralis fascia. Along with these structures, I should also remove the axillary nodes. There are level 1, level 2, level 3 nodes. Level 1 is lateral to pectoralis minor. This is pectoralis minor muscle. Lateral to pectoralis minor, it is level 1 nodes. Behind pectoralis minor is level 2. Medial to pectoralis minor is level 3. All these nodes also will be removed. So please remember, when I am doing MRM, what are the structures I will remove? I will remove nipple, areola, breast tissue, tumor and pectoralis fascia. I will remove lateral to pectoralis minor, behind pectoralis minor, medial to pectoralis minor. I will remove all the nodes. I will preserve A, B, C, D. I will preserve A, B, C, D and M. What are the structures preserved in MR and D? Axillary vessels, Bell's nerve, cephalic vein, nerve to latissimus dorsi, and one muscle, that is pectoralis major muscle. So these are the structures I will preserve. Minimum how many nodes will be removed? If you are a good surgeon, you should remove minimum 10 nodes. Minimum 10 nodes are removed. While doing this modified radical mastectomy, there are 3 maneuvers which we will be doing. There are 3 maneuvers. What are they? Patty's maneuver, Auchincloss modification, Scanlon modification. These are 3 important modifications from Swartz. In Patty's, to remove the nodes, I remove the pectoralis minor. I remove the pectoralis minor as Patty's. Auchincloss, remember Auchincloss is a strong person, he will retract the pectoralis minor. We usually call the first year PG as Auchincloss to come and retract the pectoralis minor. Scanlon is cut and resuture the pectoralis minor. Cut and resuture the pectoralis minor is Scanlon. So these are the points about modified radical mastectomy. So these are the points you should not forget about modified radical mastectomy. In this, the question you can expect in exam is boundaries of axillary dissection. This is an axilla. All the notes are here. No, I want you to tell the boundaries of axillary dissection. Superior boundary is axillary artery and axillary vein. Axillary artery and axillary vein are the superior boundaries. Medial boundary is this. What is this? What is this medial boundary? What is this nerve? It is Bell's nerve is the medial boundary. Lateral boundary is this. This is one pedicle. What is this pedicle? This pedicle should be very carefully preserved, known as thoracodorsal pedicle. It contains artery, vein and nerve. Thoracodorsal pedicle. Okay, this is thoracodorsal pedicle. And inferiorly you have one nerve, one vein, that is angular vein. So this is the boundary of axillary dissection. So please don't forget the boundaries of, sorry, this is cephalic vein. Inferiorly we have cephalic vein. So these are the veins you should not forget, boundaries you should not forget. Sorry, it's an angular vein only. It's an angular vein, Bell's nerve, thoracodorsal pedicle, axillary vessels. So these are the boundaries of axillary dissection. And what is Halsted ligament? The Halsted ligament forms the apex. Apex is Halsted ligament. It's not a boundary. The axillary goes, no, it enters at the apex is Halsted ligament. Okay, Halsted ligament is apex. So these are the boundaries. This question can come for an exam. This picture showing you axillary dissection. You can see Achin-Claus operation going on here. Pectoralis minor is retracted. Can you see the Bell's nerve? What we are holding here is thoracodorsal pedicle. The superior boundary is, you can see the thoracodorsal pedicle, Bell's nerve, superiorly axillary vessels, and there will be one more vein going, inferior angular vein here, which is not shown in this picture. We have to remove all the nodes in this area, and in this picture you are seeing the surgeon is removing the Rotter's nodes. So what are Rotter's nodes? They are interpectoral nodes. So now the questions from this MRM. What is the most common nerve injured? What is the most common nerve injured in MRM operation? It is, what are they? They are the intercostobrachial nerves, which are nothing but cutaneous nerves. So they are nothing but cutaneous nerves. Intercostobrachial nerve is the most common nerve injured. So it is intercostobrachial nerve. Okay, please don't forget this. Intercostobrachial nerve is the most common nerve injured during MRM. So this is a picture showing some images from this chapter. This is a picture showing you popcorn calcification of fibroadenoma. You know that very well. Popcorn calcification of fibroadenoma. Can you tell me what is this tumor? Such a huge tumor with no lymph node involvement will be there. No muscle involvement will be there. No lymph node involvement, no muscle involvement, but there is a huge tumor looking like a fibroadenoma. So what is this? It is Phyllodes tumor. So treatment is simple mastectomy or just excision of the lesion alone is enough. Simple mastectomy or excision is enough for this Phyllodes tumor. Yes, most common complication is seroma, not lymphedema. The most common complication of modified radical mastectomy is seroma. That is why after mastectomy what we do? After mastectomy being done, we keep drains. We keep one drain like this. We keep drains with the two tubes. We will be keeping a suction drain. This drain will be removed on which day? Palian law. Suction drain is kept to remove the seroma, and this drain should be removed on 5th post-op day. So please don't forget, suction drain should be removed on 5th post-op day. So it's not very important for your exams. This Phyllodes tumor is an expected MCQ. Why it is known as Phyllodes means leaf-like. When you cut it, it looks like a leaf. So what is the name of this disease? It's a thrombophlebitis of the veins over the chest wall, known as Manders disease. So reassurance is a treatment for Manders disease. There is no surgery needed for not 48 hours, Jack Frost. It is for 5 days. 5 days, okay. So drain should be left for 5 days. If the drain falls in between, like second day or third day it falls, we have to make a tight strapping and we have to aspirate repeatedly. The seroma should be aspirated repeatedly. So that's a Manders disease. Okay. No, there is no CC and all for to be practical for a mastectomy drain MCQ. If you want to remember it as 5 days. But practically, the oncosurgeons, they leave the drain even for 10 to 15 days until the drain becomes very less, like 10 ml, 15 ml, until they leave it. Okay. So this is Mondus disease. And what is this surgery known as? What is this surgery? It is done for duct papilloma or duct ectasia. There is one surgery done. They have removed only one duct by a tennis racket shaped incision like this. This is known as microdocectomy. It is known as microdocectomy done here. So in all cancers, when will you irradiate the axilla? Joseph is asking, when will you irradiate the axilla? Irradiation of axilla is done for the following indications. Number one, when there is an extra capsular spread of lymph node. The lymph node, the tumor has spread beyond the capsule. Number one. Less than 10 nodes removed by the surgeon. Less than 10 nodes removed by the surgeon while doing surgery. Or when there is no axillary dissection done. These are the indications of irradiation of axilla. If you have done an axillary dissection, no need to do irradiation at all. If you have done an excellent axillary dissection, you no need to do irradiation. In such case, if you do irradiation, the problem of irradiation of axilla is lymphedema of the arm. So we should try to do surgically all the node clearance. We should try to remove surgically all the node clearance. Okay. So please don't get confused with this. So irradiation of axilla is done only for extracapsular spread, less than 10 nodes removed, no axillary dissection done. So microdocectomy image only shown here. I have not shown the Hatfield operation. Don't get confused with Hatfield. Hatfield is different. Hatfield is, see, this is a breast, nipple, this is a breast. These are the ducts going towards the nipple. I don't have an image of Hatfields. So what we do is, we will do a conical excision like this of all the ducts. So conically I will excise radical excision of all ducts. Hereafter this patient cannot give breast milk at all through that breast. So this is done for periductal mastitis, which is nothing but duct ectasia only. Other name of duct ectasia complication only is known as periductal mastitis. It is also known as Zuska disease. So it is also known as periductal mastitis or Zuska disease. Please don't forget this. So Hatfield operation is different. Conical excision of all the ducts is known as Hatfield operation. It is also known as periductal mastitis or Zuska disease. Van Nuys grading is a high yield MCQ. Azar, you have to remember that Van Nuys grading is a grading done for ductal cancer in situ patients. Ductal cancer in situ patients based on patient age, size of the tumor, margin clearance, etc. We have to know about Van Nuys grading. I have already uploaded a 40-page last minute revision tabular column for your exams. Please read those 40 pages tabular column for National Board exam just 2 days before exam. So all the scoring I have compiled together and I have uploaded in my Telegram channel Surgery Sixer. So please use that last minute revision table. That's more important. Okay. And there are recent questions from breast reconstruction of after mastectomy. This is rectus abdominis muscle. First of all, get a clear idea about the muscles. This is rectus abdominis muscle. Right side, this is left side rectus abdominis muscle. This is the artery running from above downwards. This is artery running from below upwards. This is superior epigastric artery. This is inferior epigastric artery. Once upon a time, the breast reconstruction was done with the help of with the help of, for example, I have removed a right breast. What I will do is I will use the opposite side rectus abdominis muscle. From here will be shifted here like this. So this is known as TRAM flap. Transverse rectus abdominis myocutaneous flap. From the opposite side we take the muscle and use it here. This is TRAM flap based on pedicle. It is superior epigastric artery. Pedicle flap is based on superior epigastric artery. So pedicle means, please remember, this is pedicle. This is rectus abdominis muscle will be shifted like this without any microvascular anastomosis. Just like that, I can shift it here. This is tram flap. Free flap, I will take it out. Please remember, I have now taken it out and I will keep it here and suture it with some vessels there. That is known as free flap. Free flap is done with the help of inferior epigastric artery. So tram flap is of two types. Using the superior epigastric artery is pedicle flap. Using inferior epigastric artery is free flap. Some small breast reconstruction we can use latissimus dorsi flap also. LD flap also can be used. So, but they won't ask you more detail about LD flap. But there will be asking you about one more flap, that is DIEP flap. DIEP flap. This is the latest flap used. Most surgeons use this flap. Deep inferior epigastric perforation flap, in which we are not going to use the muscle at all. See this lady we have used in this lady, this is a very old picture when I was doing MS. This is the rectus abdominis muscle. This muscle is shifted like this as a pedicle flap in this lady. This is a picture showing you tram flap. What I am going to show you is, this is a fat area containing this inferior epigastric artery. What we will do is, we will cut and remove this and we will keep it here and anastomose this artery with the nearby artery, internal mammary artery or some other artery. So this is DIEP flap. We don't use muscle. Deep inferior epigastric perforator flap. It is a latest flap. It is a latest flap. You should not forget. This is skin, subcutaneous tissue and fat. Okay, it is skin, subcutaneous tissue and fat included in DIEP flap, not includes muscle. Okay. So any doubt you have in breast? Some of you asked for breast conservative surgery. It is a very huge topic for a separate session. Breast conservative surgery includes 4 steps. Breast conservative surgery is done only for early breast cancers. It includes 4 steps. Step number 1, tumor should be wide locally excised. Wide local excision of the tumor is done, number 1. Number 2, I should know about the axilla, whether axillary node is positive or axillary node negative. I should know by doing a sentinel node biopsy. If axillary node is positive, I should go for axillary dissection. If it is negative, I should go for radiotherapy to the axilla. So please remember, what is breast cancer surgery? It includes 4 points. Point number 1, I should do a wide local excision of the tumor. What is the margin? 1 mm margin or a negative margin. 1 mm minimum margin is needed. Yes, DIEP is a free flap. DIEP is a free flap. This axillary node positive cases, we should do a axillary dissection. Negative cases, I should do radiotherapy to the axilla. Number 3, radiotherapy to remaining breast. Because we have not removed the entire breast, so what should I do? I should give radiotherapy to the remaining breast. The 4th point is most important. I should keep the patient on follow-up. So these 4 together is known as breast conservative surgery. No, latissimus dorsi is a separate flap. It can be shifted from posterior, it can be shifted to anterior. It is usually done for small reconstructions, not for huge breast reconstruction. Latissimus dorsi is a separate flap. It can be used for small area reconstruction of breast. Usually for an entire breast reconstruction, LD flap will not be sufficient. We have to depend on DIEP flap only. So breast conservative surgery, please don't forget wide local excision, sentinel node biopsy, radiotherapy to remaining breast and follow-up are done. Okay, this point you should not forget. Any doubt you have in breast, don't worry, you can visit my YouTube channel. I have a video there uploaded for 2 hours plus discussion of CA breast is there. Typical for final MBBS students, it's available. You can visit my YouTube channel and you can see that. Okay. So follow-up is done every 6 months. Once the patient should come for hospital, we have to do clinical examination of the operative area And follow up is done. If there is a breast conservative surgery done, they should come for regular follow up, 6 monthly. They should come for follow up, and the follow up we have to use MRI. That's the interesting point. We should not use mammography or ultrasound, we should use MRI. MRI. Okay. So dial clock, vertical, horizontal methods, they won't ask you a national board exam, they are AIMS questions. So if this is a breast, if I examine the breast from inside to outside, inside to outside, inside to outside, inside to outside like this, it is known as dial clock method. Dial clock method or circumferential method. If I examine the breast from outside to inside, outside to inside, outside to inside, outside to inside like this, it is known as spoke wheel method. This is an AIMS question, it's based on an AIMS paper. So usually national board examiners will not ask those questions, which is not there in book. This is spoke wheel method, dial clock method, and another method is like this. Vertical strip method. This is known as vertical strip method. It is known as vertical strip method. Okay. So let us go to the next chapter because it's already 2 hours. So the latest classification in Bailey and Lowe, I want you to remember Naigus classification and old classifications of Gilbert, everything has been removed in New Bailey. So expected MCQ from New Bailey will be European hernia classification for inguinal hernias. It can be primary or recurrent. It is a lateral or medial or femoral. And the defect size can be mentioned as 1 finger entering is 1.5 centimeter, 2 finger entering the defect is 3 centimeter. So if I say PL2, I can simply say the hernia as PL2. P for primary, L for indirect hernia, and 2 means it is 3 centimeter defect. So simple short form I can tell about the hernias using European hernia classification. So please remember, if I say PM3, it means it is a direct hernia. The defect size is 3 into 1.5, it is 4.5 centimeter defect, and it is primary hernia. Like that I can simply say whether it is a primary or it is a recurrent or it is a medial or lateral or femoral, defect size, everything can be given with this European Hernia Society. So this is a picture showing you an irreducible hernia. A picture showing you an irreducible hernia. So this is a picture showing you a femoral hernia. So femoral hernia, why this is an abstracted femoral hernia shown here, and this is a picture showing you an old instrument used for hernias. No more it is being advised nowadays. It is truss. It is truss. These are all some images you can get in the exam. So now this question is a repeat MCQ. There are 2 types of mesh you should not forget. The mesh is heavyweight mesh and lightweight mesh. What is the weight? Lightweight mesh means what? The mesh size is less than 40 grams per meter square. Heavyweight is more than 80 grams per meter square. Which is best for hernia repair? Can you tell me which is best for hernia repair? Lightweight or heavyweight? Best for hernia repairs is lightweight mesh, because they go for, even if they go for contracture, they will occupy more of the space. And if there is a defect like this, we have to overlap at least 2 centimeter with the mesh. At least 2 centimeter I should overlap on all sides. Even up to 5 centimeter I can overlap. So 2 to 5 centimeter minimum needed. So lightweight mesh is the ideal mesh used in practice nowadays. Lightweight mesh have better tissue integration, larger pores, and better comfort to the patient. Nobody is using heavyweight mesh nowadays. All of us are using only lightweight mesh made up of polypropylene mesh. It is the latest used mesh. Mesh color is white in color. It's a picture showing you a lightweight mesh. So in hernias, my aim of discussion is to discuss on laparoscopic anatomy of hernia. So my aim is not to discuss the general hernias because you will be knowing them very well. I wanted to discuss about the laparoscopic hernias. So So this is a inguinal ligament. The patient I am seeing from above downwards. This is penis, this is scrotum, like that you remember. This is inguinal ligament. This is the abdominal wall. I am seeing the patient from head end. I am now drawing the peritoneum. This is the peritoneum of the patient. This is peritoneum containing the bowel and other structures inside, like this. So now you are going to see two important spaces in the pre-peritoneal area. This is one space and this is another space. So this space behind the pubic symphysis is known as retropubic space of, what is the name? Retropubic space of Retzius. Please remember, retropubic space of Retzius. And this space behind the inguinal canal, it is known as Bográs space. Our entire hernia operation happens in these two spaces only. Mesh material is polypropylene, Bhagraj. It is polypropylene. So the retropubic space of Retzius and Bográs space are the two important spaces. In these two spaces only we have all the triangles. Hereafter I will be removing these two spaces, Bográs space and retropubic space of Retzius. Now I am going to enter this space by laparoscopy. I will see the deep ring here. This is deep ring. I won't see the superficial ring from inside, but I will see the deep ring from inside. Into the deep ring, I will see the vas deferens entering. This is vas entering. Vas deferens entering the deep ring to go to the testis. I can see here gonadal arteries and veins. Testicular artery and testicular vein I am seeing. Now you can see the two triangles are already formed. You can see the two triangles are formed. So this triangle which I am highlighting in yellow color is what triangle, and this triangle I am highlighting in blue color is what triangle. These are the two triangles of essential point you should know in exam. So this is triangle of doom. This is triangle of pain. Triangle of doom is bounded by vas deferens, gonadal vessels and peritoneum, reflected peritoneum. These are the boundaries of triangle of doom. Content. What is the content of triangle of doom? This is the content of triangle of doom. It is external iliac vein and external iliac artery will be there inside the triangle. So contents are external iliac artery, external iliac vein. The patient will doom if you injure some structure inside. That is why it is known as triangle of doom. External iliac artery and external iliac vein will be there. Triangle of pain bounded by gonadal vessels, peritoneum. What is the third boundary? Can anybody tell me what is the third boundary? It is not femoral artery, Jack Frost. It is external iliac artery and external iliac vein. Femoral artery comes only after the inguinal ligament, no? So it is known as iliac vessels. So gonadal vessels, peritoneum, and third point is iliopubic tract. This area is known as iliopubic tract. We don't see the inguinal ligament from inside, but we see iliopubic tract. Gonadal vessels, peritoneum, iliopubic tract forms the boundary of triangle of pain. It contains four nerves. Lateral cutaneous nerve, anterior cutaneous nerve, femoral nerve, femoral branch of genitofemoral. So triangle of pain contains four nerves: lateral cutaneous nerve, anterior cutaneous nerve, femoral branch of genitofemoral nerve. These are the nerves seen inside the triangle of pain. Most common nerve injured in laparoscopic operation is what? In laparoscopic surgery, most common nerve injured is in laparoscopy L for L, lateral cutaneous nerve. Okay, most common nerve injured is lateral cutaneous nerve is injured. So lateral cutaneous nerve, anterior cutaneous nerve, femoral branch of genitofemoral nerve. So these are the boundaries of triangle of pain. If I go through laparoscopy from inside abdomen, through the abdomen, if I go inside and if I keep a mesh here, it is known as, if I go via this way, it is known as tap. If I go via this way directly extraperitoneal, is known as tip. Tap is transabdominal pre-peritoneal repair. Tip is total extraperitoneal repair. So which is difficult for surgeon, which is having a long learning curve, means tip is long learning curve. To learn tip is very difficult. Tap is easy to do. Surgeons, we are very much having orientation with the lab, so we'll be doing tap easily. Tip will have a long learning curve. So the same anatomy which I showed you here is, it's shown here. You can see the anatomy again. Vas deferens is here. Gonadal vessels are here. This is a triangle of doom. So this is triangle of pain. A triangle of doom and triangle of pain. Don't forget, they are essential questions for your exams. So space of Ritzius and space of Bogros. So this question came last year in INI common entrance test. Myopectineal orifice of Frouchard. This is the space where we actually keep a mesh like this from behind. In this space only we keep a mesh fully. Myopectineal orifice of Frouchard is bound by, medially it is having rectus abdominis. Can you see here? Rectus abdominis medially. Laterally we have iliopsoas muscle. Superiorly we have conjoint tendon. Inferiorly we have pecten pubis. So this is myopectineal orifice of Frouchard. You want to know corona martis? Corona martis is usually a neat SS question. They won't ask you for PG, I'll tell you. So rectus sheath, pecten pubis, iliopsoas muscle, conjoint tendon. This together forms the myopectineal orifice of Frouchard. If you want to know about corona martis, I am drawing you the corona martis. This is common iliac artery, divides into internal iliac artery, and this is external iliac artery. The external iliac artery gives the branch inferior epigastric artery. Internal iliac artery gives a branch obturator artery. This is a normal anatomy. You can see this is a normal anatomy, you should know. So common iliac artery, external iliac artery, inferior epigastric artery, internal iliac artery, obturator artery. This is a normal anatomy, you should know. So this is what's seen in most of the patients. This is seen in 70% of the patients. 20 to 30% of us may have this abnormal artery connecting inferior epigastric artery with obturator artery, known as abnormal obturator artery. It is exactly lying on a lacunar ligament. So when I try to cut the lacunar ligament, or when I do something here, I can injure the abnormal obturator artery and it will bleed torrentially and patient will die. Now you can see corona martis. Corona martis, or circle of death, is formed by what are the vessels? Circle of death is formed by internal iliac artery, external iliac artery, obturator artery, inferior epigastric artery, and abnormal obturator artery together forms this corona martis. It is forming the corona martis. Abnormal obturator artery is running on the lacunar ligament, will get injured, and it will cause torrential bleeding during laparoscopy or femoral hernia surgery. That is known as corona martis, or circle of death. So we are coming to the last question and answer discussion from this module. So regarding the tumors of parotid gland, false statement is, yes, answer the question. Question number 1. Regarding the tumors of parotid gland, false statement is, most common benign tumor is pleomorphic adenoma, is true. pleomorphic adenoma is true. That is correct. Warthin's tumor is common among males is true. Warthin's is common in smokers is true. Pleomorphic adenoma produces perineural invasion is absolutely wrong. I told you it is wrong. Perineural invasion is seen with adenoid cystic cancer. Okay, Warthin's tumor is appearing hot spot in technetium scan is correct. So these are all typical repeat questions of NEET. A patient operated for paroidectomy developed pain and erythema in the side of face with a sweating at the time of eating. Pain and erythema at the time of eating with the sweating. Which of the following is wrong? This is about the Fraze syndrome they are asking. Could have been prevented by keeping stenomastoid flap. That is true. Treated by Jacobson's neurectomy. That is also true. We can cut the glossopharyngeal nerve near the tympanic membrane. Starch iodine test is used for diagnosis is true. Post-ganglionic what nerve is injured? It is not sympathetic. It is parasympathetic nerve is injured. Okay. So let us see how you are going to answer this question. Mrs. Kamala, 30 years female. These are the questions you are going to get this in this National Board exam as per our prediction. You are going to get more and more of clinical pattern questions like this only. Presented with sudden enlargement of thyroid with palpation. She is having Nafziger's test positive. So Nafziger's means she is having exophthalmos. When you see from above, the eyeballs are protruding. Nafziger's test positive. Pulse rate 120. Fine tremors are there. She gives history of 10 kg weight loss. She gives history of 3 months amenorrhea. She is pregnant. So color positive. She is pregnant. Long acting thyroid stimulator positive is nothing but Graves' disease. Question on Graves' disease. That's all. You have to know what question is. Ideal treatment for this lady is to do subtotal thyroidectomy is true. It is true. Patient is pregnant. I cannot use radioactive iodine at this point of time. So radioactive iodine is a drug of choice, but I cannot use it because she is having pregnancy baby. So I have to go for thyroidectomy, true. Radioactive iodine therapy is contraindicated in this patient is true. FNAC is not useful for this patient. That is also true. She is provided with the carbimazole. We should not give carbimazole. Carbimazole is contraindicated during pregnancy. We should use propyl thiouracil. Propyl thiouracil should be used. That is a. So actually, which of the following is not the true, which is a wrong statement? Answer is false statement. The question is asking on false statement. The false statement is carbimazole is wrong. We should use propyl thiouracil. Simple question on Graves' disease. So the question on thyroid is, Mr. Kumar presented with neck swelling for past 3 months. He is having Dupuytren's contracture. The neck swelling is hard on palpation. He is having TSH increase. TSH increase means what? Patient is hypothyroidism. So this is a case of Riedel's thyroid. From the history, most of the time what you should come know, you should come to your diagnosis. So this is Riedel's thyroiditis. So Riedel's thyroiditis, he may be benefited by tamoxifen. Initially there will be hyperthyroidism is wrong. He will be hypo from the beginning. So Riedel's cases will be hypo always. There is no scenario of hyper at all. We need to do true cut biopsy to confirm diagnosis is true. So please remember this point. Okay, propyl thiouracil is used in first trimester. Yes. Yeah, the patient is in 3 months amenorrhea, so we have to go for propyl thiouracil in this case. We should not use carbimazole at this point of time. In third trimester, you can use any drug. Okay. So Mr. Ramu, a patient with 6 centimeter papillary cancer thyroid, underwent total thyroidectomy with MRND of left side neck. So he has done a total thyroidectomy. He has done a neck node dissection also. Regarding the things that must be done in the post-operative period, false statement is. Patient must undergo thyroid scan to look for mets is true. TSH suppression is needed in the postoperative period is absolutely true. Calcitonin is used as a tumor marker in the follow-up is true or false. It is not medullary cancer, it's a papillary cancer. So calcitonin is not a tumor marker. Post-op recurrence is monitored with the help of thyroglobulin is a tumor marker in this case. Okay, it is. Okay, that is true. Yes, that's correct. Azar, Hashimoto's thyroiditis will have hyperthyroidism. Riedel's will never have hyperthyroidism. So this here is called calcitonin is not a tumor marker. So the question is again a simple question. Luminal B stands for which of the following? B means all positive. ER/PR, HER2 positive is known as B. All are positive is B. B for all positive. So false regarding the accelerated dissection procedure done for breast cancer is lateral boundary is thoracodorsal pedicle. True. Minimum 10 nodes removed. True. In Achin class there will be retraction of the pectoralis minor done. True. Most common nerve injured is Bell's nerve. Wrong. It is intercostobrachial nerve is the most common nerve injured in this operation. Okay. So this is a question came in INI common entrance test last section. New question. As per European Hernia Society classification, it is not there in books. It is taken from internet. Incisional hernia at the level of umbilicus is given in the term. So this is a European hernia. For inguinal hernia, I told you. Now it is incisional hernia. You should remember M1 is for xiphisternum. Epigastric hernia is M2 here. M1, M2. Umbilical is M3. That is the question asked. So please remember the question is asking on umbilical. Umbilical is M3. Umbilical is M3. M4 is infraumbilical. M5 is suprapubic. M1, M2, M3, M4, M5. So M3 is umbilical. Okay. So this question is a new question. So just remember umbilicus is 3, above 1 and 2, below 4 and 5. That's all. So this is also a new question asked regarding the boundaries of laparoscopic anatomy of inguinal hernia. I am telling you, sure you will get one question from laparoscopic anatomy. Medial boundary of triangle of doom is vas deferens. True. Lateral boundary of triangle of pain is iliopubic tract is true. Myopectineal orifice is bounded by internal oblique and transverse abdominis superiorly is true. Myopectineal orifice is bounded by iliopubic tract inferiorly is wrong. I told you it is bounded by pecten pubis. Not iliopubic tract, it is bounded by pecten pubis. Okay. So don't worry, this video will be available in this channel itself. You can use it for revision, and if you want a fast revision of all the systems, it is already available in my YouTube channel. You can see all the videos are available there. As a question paper leak session is there in this channel, you can visit for the full revision. And I will be having another session on instruments, named operations and specimens for 1 hour, just 3 to 4 days before exam. So please attend this session in future. I will be doing this in my channel itself. You can follow my channel, and you can follow me on my Telegram channel, Surgery Sixer. All the PDFs of most of the classes are there in that channel. You can use it. Telegram Surgery Sixer channel, or you can follow me on my Instagram Surgery Sixer or Facebook Surgery Sixer. These are the channels in Facebook as well as Instagram, and you can follow us in Dr. Dorril's YouTube channel as well as in this thing. Okay. I'll be they will put the date, Ajit Sharma. I will inform it. Don't worry. So lab instruments, lab surgeries, lab surgeries are already there in this channel. If you go know some laparoscopic important points are there. If you want, you can see, or else I can add up in the instruments. I will add the lab instruments also. Okay. So thank you all for the session. Any doubts, you can always post in the Telegram Surgery Sixer group. It will be useful for all of us. So you can be always posting it. So any doubts you have? Yes. Any doubts if you have, you can always post it. Most of the videos are available in Dr. Dorril's app, so you can always visit the app, and you can see in FMG section there is all the videos are revised, so you can use it. So thank you all for attending the session and making the session interactive. So all the best for your exams. I will meet you a few days before the exam, just 3-4 days before the exam. So it will be helpful for you to clear any last minute doubts, and also to rectify the important aspects of important instruments, surgeries, etc. I will discuss during that time. So thank you all. Thank you so much. So staging wise, I request you guys, please remember about oral cancer and breast cancer staging is must. You must be thorough with these two stagings. Everything you must be thorough in oral cancer and breast cancer staging. Okay. So this YouTube video will be available in the Dr. Tutorials channel. You can always visit the video and you can see the video afterwards also. So thank you all. Thank you so much.